Thank you. Thank you for getting on what is probably Zoom number, we don't know what, after a long day for the first of our Medify webinar series. We feel really fortunate that we had the opportunity to change plans, pivot quickly, and run the Medify conference as our first ever virtual conference in September. Our turnout numbers surpassed any in-person conference that we've had so far, and the feedback and the response was so positive that we decided to take the opportunity to continue meeting in this online forum, in addition to the very active listserv and the conversations that continue to happen. As you on the listserv know, we sent out a survey asking for topics of interest, and so what we really tried to do with this series is target the topics that we heard you wanted to know more about, both in the conference feedback and in the survey itself. And I would encourage you, please, when you fill out the feedback forms at the end of this session, to continue to let us know what's working for you, about the format, about topics that you'd like to hear, other suggestions, because it's really meaningful to us as we launch this inaugural series and hope to make it really meaningful for you. So I'm pleased to welcome Dr. Tanya Hauck and Stephanie Rochon for our first session on stimulants in RAAM, Pharmacologic and Contingency Management. Dr. Tanya Hauck is an addiction psychiatrist at the Center for Addiction and Mental Health and a lecturer in the Department of Psychiatry at the University of Toronto. Her research interests include the epidemiology of addictions and addiction psychiatry in Toronto. Stephanie Rochon is a regulated pharmacy technician at St. Leonard's Community Services. She's the supervisor and coordinator of the Brant Haldeman Norfolk RAAM Clinic. She's previously worked in addiction medicine clinics and pharmacies to integrate services and improve access to evidence-based treatments in rural communities. So in what might be a first, Stephanie and Tanya sent me the bio for the Brant RAAM, which I think is kind of great. And it left me wanting to know much more. So we feel like the RAAM is the third entity or the third presenter in this topic that hopefully we'll get to hear a lot more about. So the Brant Haldeman Norfolk RAAM, BHN RAAM Clinic, is a multidisciplinary team offering patient-centered collaborative treatment for concurrent disorders, alcohol, opioid, methamphetamine, stimulant, and benzodiazepine use disorders. The team provides mental health and addictions care through teamwork, technology, and integration. The BHN RAAM Clinic is a working partnership between addiction physicians and psychiatrists, St. Leonard's Community Services Addictions and Mental Health, the Brant Community Healthcare System, the Canadian Mental Health Association, Brant Haldeman Norfolk Branch. I apologize that I'm going to mangle this. The Duadade Nice Aboriginal Health Center. I should have asked for assistance with pronunciation, and I apologize. Grand River Community Healthcare Center and Haldeman War Memorial Hospital. That sounds like the most sort of integrated collaborative system I could ever imagine. Patients can be supported by case management, physicians or nurse practitioners, addiction psychiatrists, mental health counselors, concurrent disorders counseling, a mental health social worker, an Indigenous mental health and addictions counselor, and a peer support worker. So without further ado, I turn the session over to Tanya and Stephanie. Please post chats or comments in the chat section. We'll be using the last half hour, hopefully, for a great conversation. And I'll join you again at 8 o'clock.
Thank you. I just really want to quickly, somebody's asking about docking our faces, and I think does everyone have to do that themselves? Maybe? Because we had to dock ourselves in our view of it, and I'm just wondering if that's one of the reasons, if you are still seeing us.
It's been done for attendees as well.
Okay. So big thank you to Medify for having us, and we're just really happy to be here and give this presentation. And so just bear with us if we have any difficulties with the system, although they did orient us really well. So this is really about stimulants in the RAAM. That's why we introduced the RAAM as a participant as well, because it is about that setting and relevant sort of information to that setting in particular, as opposed to maybe other settings. So just to go through a disclosure, so I just have one disclosure that my fellowship was funded by Bellwood Health Services. And just as a sort of point to kind of anchor this, this came out actually as I was starting to work in the RAAM. So the RAAM clinic, I work over OTN through CAMH, and the RAAM clinic is in 3 communities, which rotates throughout the week, in Brantford, Denville, and Simcoe, Ontario, and both the city of Brantford and also in the rural communities. And as was so nicely introduced, there's just such a different number of providers and agencies and collaboration happening there. And one of the things immediately that was apparent is that there are a lot of patients presenting to RAAM with stimulant use disorder, and that it was often very hard to access services. And this around that time, this article came out about someone seeking treatment for psychosis related to stimulants and really having difficulty accessing care. And that was really one of our goals, was integrating that into the rest of RAAM treatment, making that a part of it. So our objectives today were both related to identifying evidence related to pharmacological treatment for stimulant use disorder, including stimulant replacement. That was a specific question we were asked. To describe the elements of contingency management, and specifically in a RAAM, how that would look and how that would work. And then to talk briefly about stimulant-induced psychosis, because we really see quite a bit of that, and we provide sort of a means of patients accessing treatment. So these topics below are not specifically covered today, and we're focusing sort of on those above. So to start with stimulant use disorder, just a really brief background. I think everyone's quite familiar. But stimulants are these compounds that act on the dopamine system. They sort of vary between cocaine and amphetamine. Cocaine having a half-life of 45 to 90 minutes, and amphetamine being somewhat longer. They both block reuptake of neurotransmitters, but amphetamines in particular cause release of additional dopamine and a much sort of more intense release of dopamine, and that leads to reinforcement as well. In the long term, and I think this is important because it relates to treatment and access to treatment, there's depletion of neurotransmitters. There's actually neurotoxicity from all of that dopamine that's released, which can have a number of neurocognitive impacts. And it's a high rate and high risk of developing dependence with even relatively brief periods of use. So this was actually declining, such as methamphetamine use, but is starting to increase again. These are compounds that were at one point prescribed and then were reclassified as scheduled drugs due to the risk of use disorder. And over the last 10 years, methamphetamine use in particular has really been increasing. There are many reasons, including many psychosocial reasons and adversity and trauma that lead to a higher risk of developing a use disorder, as well as some genetic predisposition. At the moment, the estimated use in the United States is about 3% of the population for methamphetamine and about 0.3% and 0.7% for cocaine, with an overall 0.3% prevalence of stimulant use disorder. So there may be a number of individuals who use, on occasion, for example, cocaine, but don't actually meet the criteria for a use disorder, as opposed to the prevalence of the use disorder. So again, in the RAAM, we, as with opioids, we generally use this standard criteria for the DSM to define stimulant use disorder, either amphetamine type or cocaine type. Again, these criteria I think are really important to reflect on when we're thinking about, when someone's seeking care, what they're looking for, what would be helpful to them, is sort of the impact on life. So not just the fact that they've used, that's really not the part that defines the use disorder, but the impact that's had on their relationships, on their ability to pursue any sort of educational, vocational goals they may have, their overall quality of life, risks to their health, worsening mental or physical health, and so on. So it's generally over a period of 12 months and characterized by its severity. So we do, on our intake, and Stephanie's going to mention the intake and kind of actually the role the intake has in providing care, talk about kind of just, going over these criteria. So pharmacological treatment, and I think this is really important, is pretty much everything actually in this talk is off-label, right? So they actually asked when we came up with the objectives to talk about what was on label, what was on label. And basically everything is off label, right? Because there isn't an on label medication for the treatment of stimulant use disorder. So that's really important to remember. And in looking at all of these studies, there really is, as they say in the ASM principles, there's no well-established, clearly effective pharmacotherapy. So sometimes we're trying things out. We're doing that based on comorbidities a lot of the time. We're selecting based on other concurrent disorders that are there, based on patient preferences. But we don't have something that works as well as opioid agonist therapy for opioids. We don't have something that works as well as naltrexone. And we do see a lot of clients, and I'm sure in other RAAMs as well, that use a number of different substances. So we're also trying to balance, the relative importance or needs of the stimulant use disorder compared to other substances of concern, based on the client goals. So although there's been a lot of interest in this, in general, there hasn't been a lot of evidence. And the psychosocial treatments have generally been somewhat more effective, although certainly there's been nothing that's been so dramatic. So just to go through kind of a number of different categories of medication. So the antidepressants do not generally improve abstinence, although there's now more evidence for mirtazapine. Certainly we use a lot of mirtazapine. Again, it's off-label, but nonetheless, based on some of this research. And adherence could be a barrier to treatment, so another thing to consider. So sertraline actually might reduce retention. There's several studies, and it's actually specifically not recommended in some of these guidelines. So I included at the end of the slides of the references. So these guidelines by Hartel-Petrie, for example, kind of go through all of the evidence related to these substances, and they're fairly recent, so it's quite helpful. There seems to be some evidence, perhaps for bupropion, for methamphetamine use, and may also off-label. It's in the CADRA guidelines for ADHD, but it can be misused and can cause medical, adverse effects, necrosis if it's injected. It also seems to be more effective in non-daily users. So one of the other unfortunate trends in all of this literature is that those individuals who start off with more control over their stimulant use and overall with a milder or more intermittent stimulant use in general have better outcomes from all of these treatments. And that's what we've seen with bupropion. In general, you have to warn patients about serotonin syndrome, particularly if they're using other substances like MDMA and if they're combining these substances together. Mirtazapine, though, has had two recent studies that were positive in MSM populations. It is generally well tolerated. It is reasonably safe. It is on label for major depressive disorder, and it is in the guidelines second line for post-traumatic stress disorder. So there's a number of reasons why it may be used. It also sometimes is used as well off-label for anxiety disorders. And certainly if there's a separate reason why patients are interested in using it, it was actually quite promising. Adherence was quite low. So again, that's something actually, and we'll get to it in the RAAM that we really target. We have a really close relationship with our colleagues in pharmacy, and they provide a lot of helpful information. If someone is receiving daily dispense methadone, that may be a role to actually offer the client, would it be helpful for you if we daily dispense the mirtazapine just so that you have your daily supply to try to improve that if they're motivated to take it, if they're finding it helpful. So there was a risk reduction in methamphetamine positive urines. Antipsychotics, so there is not a positive recommendation around the use disorder. And I think it's really clear to think about what are we trying to treat? Are we trying to treat the psychotic symptoms, which I'll get to later, or are we trying to treat the use disorder? And there isn't great evidence for the use disorder. There is a higher risk, certainly, of other adverse responses due to the depletion of dopamine, so neuroleptic malignant syndrome, movement disorders. Aripiprazole has a specific Health Canada warning for impulse control disorders, so gambling, sexual behavior, spending. It doesn't have a warning for stimulant use, but there have been some studies that have been stopped because of concerns of increased cravings or use. So certainly if use is escalating on aripiprazole that was started for some other reason, and arguably brexpiprazole has a very similar mechanism of action, at least to be mindful of that. If it's been extremely helpful and it was started for another reason, I think it's just something that has to be kind of thought of and considered in each case. But the antipsychotics, the evidence for really the use disorder doesn't seem to be there. And there have been also concerns about the dopamine blockade leading to increased use to try to overcome that blockade. Disulfiram is interesting. It actually may be helpful. Again, it may be specifically helpful in particularly motivated individuals who concurrently use alcohol, who maybe have an external contingency like their occupation, who really want to be abstinent from both. It kind of acts like its own built-in dopaminergic agent, theoretically. It seems to help some people genetically more than others. Obviously, there are significant medical risks, so anyone who would be excluded for alcohol-related reasons like unstable liver disease, worsening liver disease, certainly would not be an ideal choice. Would be contraindicated potentially. Anyone with seizures. But for some clients who are medically healthy, it may be a reasonable option. Naltrexone, I think we all really wish helped a lot. I think we're very familiar with it. We use it a great deal in the RAAM. And certainly there are many clients, if they are presenting with alcohol and stimulant use, where we would use naltrexone for their alcohol use. The data is quite limited, potentially some benefits, but really not a lot of evidence. So again, certainly if there's another reason to use it. Off-label, we also sometimes use it in gambling disorder. So again, given just a limited number of options in certain disorders, if there's informed consent about the risks and benefits, if patients are willing to have laboratory investigations, certainly then it may be reasonable. Many of our clients would be excluded because they concurrently use opioids and are on opioid agonist treatment and use stimulants. So by and large, we would find in the RAAM that many people would not be able to use them. The anticonvulsants like topiramate have been very popular at times. The data is also quite limited in terms of reducing the actual stimulant use. There have been some benefits over short periods. Certainly, occasionally, I think we've all had experiences where clients have had a really great response. I think it's reasonable to try given the limited evidence, but in particular, just being mindful in women, being mindful of anyone of childbearing age, just of the risks in pregnancy is really important. So substitution therapy. So this is something that's really emerging. It's not it's not our practice at this time. I think it's something that many people are interested in, and it comes up often at conferences, and there are a lot of active trials going on, and it's really important to try to figure this out and gather more evidence. There were several recent systematic reviews that are quite helpful. The confusing part is they tend to lump together a number of things which I wouldn't personally consider to be replacement therapy, things that are, somewhat act on dopamine but aren't, as opposed to clearly a stimulant. So, bupropion, modafinil, mixed, everything is kind of mixed together. In general, there's not great evidence about sustained cocaine abstinence, but it does seem to be helpful. There does seem to be some reduced use, particularly for cocaine. The one problematic aspect was that it didn't seem to help retention, which was interesting. Even when you are providing stimulants, the retention in treatment was not improved in the way that with opioid agonist therapy, there is a difference in retention in treatment. I don't know to what extent that's related to just the difference in the withdrawal syndromes between opioids and stimulants. Certainly very different pharmacologically. So a lot of these studies were small, so they might have been, multiple arms. This one by Schmetz was modafinil compared to amphetamine, compared to the combination, compared to placebo. A number of them are blinded, although I imagine it would be quite difficult to completely blind amphetamine compared to placebo, but there were definitely trials that were blinded. Some of them, it's very hard to tell how it was dispensed. So they say it was, they sort of give the dosing times, but you're not sure if the patients were given a supply for the day or how that worked. Some of them do explicitly explain that, which makes it a little more helpful. It did seem that higher doses of amphetamines in particular, when prescribed, did help decrease cocaine use. that did not help retention and treatment, and it didn't seem to be as effective in amphetamine use disorder. And it did seem like extended release formulations with direct observation and daily dispensing were recommended. So this review kind of talks about it being part of a trial, closely observed. This is just a summary, just showing that for cocaine use, you're seeing much more of an effect than for amphetamine. And then this paper actually was quite interesting, very thoughtfully done. It was actually a population which I think would be similar to many clients potentially presenting to a methadone clinic or presenting to a RAAM. So clients who are already receiving opioid agonist therapy, and this was oral methadone plus injectable or inhalable diacetylmorphine. So these were very supervised participants on a heroin-assisted treatment program. And so their substance of concern was, again, specifically crack cocaine, not methamphetamine, which is often more what, at least in our RAAM, we would be targeting. They did randomize, they described their blinding, they supervised the doses. There was a lot of kind of observation and engagement, and they did show a decrease in cocaine use in the trial. So these tend to be short periods of time, relatively small studies, but I mean, hopefully we will get more data. And I think in addition to getting more data, also getting parameters of use, because I think the hard part is, again, this is a highly observed structured program. That's very different from somebody receiving 30 days of a prescription stimulant with, no monitoring whatsoever. That's a completely different kind of situation. And certainly we think of how much structure goes into methadone and the involvement of so many different providers potentially. To what extent could we create a program like that, and how could we also improve retention and treatment? So psychosocial management. So for psychosocial management, I think the important thing is to consider, this is another Cochrane review, that overall these do seem to be effective. The one issue was that generally they weren't compared to nothing, right? Like it wasn't ethical. They were compared to some kind of other treatment, and that most treatments did seem to provide some kind of benefit. And so it's hard to kind of know the true effect size. Before we kind of get into that, I do again want to come back to this point about neurocognitive effects, which I don't think is appreciated enough, especially when we're trying to provide treatment. So our clinic provides a number of different treatments at once. So we were running a community reinforcement group concurrently with contingency management. We have individual counseling of a variety of modalities, some focused on trauma, some focused more on relapse prevention. And just to consider that with, a lot of psychosocial interventions do require, a lot of verbal skills, a lot of neurocognitive skills. And cocaine, and particularly amphetamine use, is associated for cognitive impairment that may persist for months, and in particular, visomotor performance, attention, inhibitory control, and verbal memory. So there may be difficulties with behavior regulation, which could result in you yelling at your counselor, which could result in you being asked to leave counseling, that kind of thing. It can be difficult to fill out complex paperwork, which is sometimes necessary in order to access programming. So all of these things, and to access housing, and to access all sorts of other things that might be your priority if you're seeking treatment. Now, this seems to be related to high levels of dopamine, which release reactive oxygen species, and neurotoxicity. There are improvements, and this really does improve with prolonged abstinence and treatment, but it takes quite a bit of time, and that's quite difficult to achieve. And so it's sort of, you have to consider this when offering particularly cognitive-based treatments and how this might impact somebody's ability to actually engage with the treatment modality. So just for context, so this is community reinforcement approach. It is sort of a CBT kind of family of treatments developed by Myers and Wolf, and there are a number of good resources about this, which I'd be happy to provide, that looks at the function of use. So this can be very helpful. A lot of if you look at kind of the materials, we'll talk about alcohol. So they will ask things like, when do you use, and sort of what's the function of that use at that time? So who are you with when you use? where do you use, when do you usually use, sort of internally, what are you thinking about before you use, and then sort of also what are you feeling physically, and then what behavior, very specifically kind of quantifying it, how much it is over how long a period. And then looking at kind of what the short-term positives are, because understanding those are there. There's something positive about using it, of course, and what they are, and then not stopping there, but going to what the long-term negatives might be. And then the idea is to kind of flip this around, to think of what would be another activity potentially that would maybe have some short-term negatives. It would have a cost in the short term. Like, I really used to enjoy boxing, but I know that when I go to the gym with my friend, I'm going to be really, really sore the next day. But in the long term, I know that when I go do that, the next day I actually feel like mentally quite a bit better and I connect with my friend. Now, this worksheet, we really struggled. Like, it was really hard if clients had used, a lot of stimulants to actually get through this kind of a worksheet. It's incredibly complex. When I teach residents this worksheet, we have this on the board. Like, everyone's, trying to figure out what column we're in. Like, it's just inherently confusing, and it's a really powerful tool. And we don't want to change evidence-based practices, but we actually ended up having to develop this version of it. Just because, at the end of the day, if we can't get through the end of the tool, practically that's not going to be very helpful. So this was more just, a simplified form. So just to consider this sort of with all therapies, and I think this is why contingency management is of the various treatments relatively helpful, and because it doesn't require that kind of cognitive structure and visuospatial skills that other strategies would require. So if you think of operant conditioning, contingency management is really using operant conditioning. So you're either adding something or you're removing something. And a reinforcer would increase the frequency of the behavior. So a positive reinforcer would be a reward that follows the behavior and increases it. And a negative one would be the escape or avoidance. So like paying taxes to avoid a fine. Positive punishment would be something like putting your hand on the stove, and it decreases the behavior. And negative punishment would be removing something after behavior to try to decrease it, like a timeout after hitting another child. So these are examples from this textbook on contingency management, on operant conditioning. So I think Stephanie's doing a slide. Yeah, no? Sorry, we don't have presenter notes, so we have to figure it out. Contingency management basically came out of these principles. So I think it is important to remember, if you're doing contingency management, it's actually a complex, structured process. If you want to use operant conditioning by itself, that can also be done. That's a bit separate, and it's sort of a simpler, sort of one-off at a time kind of process. So the idea is you're trying to find a target behavior that is measurable and important. So abstinence from substances as indicated by urine toxicology, or attendance at a counseling session. And then you're providing a concrete reinforcement like money, goods, prizes, access to privileges, or work opportunities that is contingent on producing the target behavior. So the basic principles are, you want to frequently monitor the behavior you're trying to change, and then you're trying to provide tangible, immediate positive reinforcers every time the behavior occurs. So that could be a voucher that increase with each behavior, or that could be a drawing for prizes. And then when the behavior does not occur, there's no punishment. It's just the withholding of the reward. And so we're already doing this. We do this with take-home doses. And businesses are doing this to us all the time. I mean, this is how we go buy that 10th coffee. It's based on this system. It very clearly is effective in human behavior. And in a very transparent way, it's possible to have, a relationship with the patient. None of this was hidden. We were very clear about, in contingency management, you're very clear about, your goal is abstinence. This is literally how it's going to work. We're going to explain it to you. Are you interested in this kind of treatment? So there's quite a bit of evidence to support it, really extensive studies. I think, we came to it because we really wanted to provide a full range of treatments, and because, you go to conferences and you keep hearing like contingency management, that's it's most effective, but like no one ever does it. And we're like, well, why don't we try doing it? And there's a lot of reasons why no one's doing it, and mainly it's money, and we'll get to that. But I've been asked like, oh, we could, there should be more studies, and I do think there are certainly some really nuanced studies that would be very helpful, and at the same time, there are a lot of studies that have been done, and they've really shown that it works, and so just implementation based on that extensive literature, I think, is quite feasible. So just from the beginning, this has shown consistent and strongest evidence of efficacy compared to control conditions, at least during treatment. As we've seen often, I think in many aspects, like I was getting to before with bupropion, there's often a bimodal response. So research studies also tend to see lots of clients come in, half of them or a large group of them do very well, immediately abstinent, continue to be abstinent throughout the program, win a lot of prizes, very happy. And then another group never achieve a negative urine sample, frustrated, drop out of the program. So I think future research actually looking at how to figure that part out, how to divide patients into appropriate treatments so they're not frustrated, and so that the people who benefit at the right time versus other people who maybe would benefit from a different kind of support at a different time. And also how to figure out when to enter people into it so that it's most helpful. Contingent reinforcement has been shown to be more effective than non-contingent, so that's kind of one of the most basic principles. If it's contingent on the reward, it's obviously more effective. And then, so voucher CM, which was the original kind of version, is when you get vouchers for essentially money for each thing that you're measuring, and then the vouchers start to go up with the duration, with increased duration of achieving that, as the behavior continues. And that they started to compare with community reinforcement, which is a form of behavior therapy that I mentioned, and that showed that the addition of the contingency management really did improve it. So this is again a good example of nobody was really going to give no treatment, but the addition of the CM helped the psychosocial intervention. Now, really important is that prize CM is equivalent to voucher CM, and this is important because like I said, in voucher you're giving out discrete amounts of money and those are going up, but in prize CM you're imagining a prize bowl. We actually were talking about it shouldn't be called a prize bowl, but a slip bowl, or like a bowl that has if you imagine going to like a fair, or like back when we went out to like events like that with lots of people, the carnival. And so you're pulling like a slip out of a big bowl, and that slip, half of them don't have a prize. Half of them say good job and there's no winning, and half of them say win. And then most of them, so like the bulk of them, like 60% or something, will say like small, and then slightly more, less you'll have like a number that'll be medium, and then a smaller number that'll be large, and then a very select few jumbo prizes. And that's much less expensive because the overall cost goes down because there's a lower chance of winning like the really big prize. And so you can save quite a bit of money, which is important because really finances are the biggest barrier. So this was just a comparison. A lot of these studies are now unfortunately kind of out of date. So they give like recommendations for prizes you might want, and they recommend things like boom boxes. So that needs to be updated slightly. Patient population, the other really important study is like when we look at the literature for the RAAM population, and we have a lot of, just a lot of things that we really worry about for our clients. We have a lot of, housing concerns that we're trying to deal with. That's why it's so valuable to have caseworkers involved. Just adversity, exposure to trauma, exposure to, violence, food insecurity, all sorts of these things. And I think a lot of studies will exclude these populations, and the data will actually be weaker in these populations. And actually in contingency management, they have done studies and shown that this actually works well in complex mental health needs. This works well, including schizophrenia, including trauma symptoms. So that's really important. That was really relevant to us, which is one of the reasons why we were really interested in trying this. That said, we do want to mention, and this is more just from our experience, that you do have to consider that everyone has complex mental health needs of a variety of kinds, and that CM isn't going to provide treatment for those. So if somebody's having, significant mood or psychosis or other symptoms, you just want to make sure that that's being separately addressed and attended to. And so if somebody's only in CM, kind of in the absence, it's not going to address those concerns. But very effective also in populations that are housing insecure and so on. Not as effective in forensic populations. The theory is that there are just so many contingencies already that it's not substantially adding a lot of contingencies. So this is really the manual. This is based on a lot of these research studies. It's a really clear sort of how-to guide that actually answers a lot of questions of like, what if this happens? What if that happens? What if patients complain about this? It goes through sample scripts. It's extremely useful. I highly recommend it. It gives you like sample spreadsheets. CM is like spreadsheets, like really, like you're just trying to figure out like, okay, so, how many of these prizes am I going to need, and how much is each of those going to cost, and what's going to be the average cost per person. And that's all doable, and we really found it quite doable in RAAM, and Stephanie's going to go into the details of that, but, it's just that has to get done. So again, I think the biggest thing about planning it from this book is just, you can use prize CM. It's reasonable to target it. So they actually get into this in the book that, resources are certainly an issue everywhere. It's been very hard in the pandemic, especially. So we have good evidence-based treatments on label for opioid use disorder. And we have good evidence-based treatments for alcohol use disorder. So in general, because of these resource limitations, we have reserved CM for stimulant use. It also happens to work particularly well for stimulant use. It's not that it can't be offered, but it gives you like fairly clear inclusion and exclusion criteria. So if we're also trying to just manage like who is going to be eligible and who isn't and for what reason, sort of having a clear description of what that means is helpful. And so certainly there could be other substances, but if the patient wanted to target stimulant use disorder, that was generally our criteria. It doesn't cause gambling disorder, but in theory, it is like a sort of similar pathway in terms of gambling. So they recommend you don't offer it to anyone who has a clearly identified gambling disorder in the past.
Okay, so implementing contingency management. Step one, you have to choose kind of your target behavior. For us, we wanted to make sure we were choosing something that's easily measured. You have to have the results immediately. Stimulants and opiates are your ideal choices. They can both be measured a few times a week. Cannabis can only be measured once every 30 days. Smoking and alcohol are challenging because they have to be measured several times a day. And then benzos are not reliably measured with urine drug screening, and they can be prescribed. You have to have like rapid urinary drug screening. You can't wait for broad spectrum. Important to know, when we implemented, we ended up going with stimulants because it had the least amount of treatments available in the community. Opiates itself and methadone is itself contingency management, building up areas. So that was its own reward system. Unfortunately, if your patients, though, were prescribed stimulants, this was a criteria that you had to kind of take that population out. They couldn't be prescribed stimulants because you can't tell the difference between that on a dip. The biggest barrier, I think, when you're kind of choosing, because when you start doing CM, everyone, you want to include your alcohol population, you want to include your opiate population, but due to finances, we did stick with stimulant use and lowered it down to 12 patients. Okay. And then step two, you have to have reinforcement. So your results have to be immediately. The minute the patient does a urinary drug screen, they have to have the results. We have to be able to pull vouchers immediately. Patients do not have the patience to wait. So usually we did this within 2 to 3 minutes. Vouchers were not recommended. They are much more expensive. Prizes were is what we ended up going with, and it was really exciting actually for the patients. They would get really pumped up going through, pulling the prize slips from the bowl, and then getting to go into the prize cabinet and choose which prizes they preferred. We had like no prizes, and then we had quotes and small, medium, large, and jumbo prizes. You can use it also for name in the hat for group attendance, privileges in residential settings. Okay. And then in patient selection, you have to be choosing patients that are motivated to change. Often when we have patients coming in to get treated for stimulants in the RAAM, you have them either choosing to want to continue using, it's more of a harm reduction approach, or you have patients that want to stop using or reduce. This has to be the population that wants to stop using or reduce using. It's not possible to assess if a patient has reduced use within the week. They have to be completely stopping. And you can't, as Tanya had said earlier, you can't be choosing patients that have a gambling disorder. Okay. Practical issues. So when we started contingency management, we had to order extra sets of tests. So you have to have methamphetamines, amphetamines, cocaine test strips. You have to have access to immediate rewards, and then it's best suited for an OAT setting. When we launched, we did this mostly with donations in the community. So there was a concern with like how much extra labor this would bring to the clinic. But because our clinic was well situated to do OAT, this was not too much to add on to that. And so reinforcement. Having a prize cabinet that is readily accessible and open for the patients to be able to see is key. On your first day, which I'll go into just a bit down, you're going to want to kind of go through and kind of prime the patients and be like, this is what we're going to do. And when you show them the prizes, they get excited to stop wanting to use. And then they want to set up like weekly plans to try to figure out how. And the prizes themselves are like motivation to want to engage in the treatment. Okay, back to you, Dr. Hauck.
I just wanted to say the book will actually talk about letting people handle things to try to really engage that dopamine system when they're home that week and their friend comes over and they're like, no, like it really, and the book talks about scripts about this. Like I was thinking about this. This is hard with COVID. We can't have people like handling the prize cabinet. So it has been a whole other struggle with COVID. Sorry.
Sorry, I think this one's you.
Okay. So this is an example. Sort of, if you want to, you can enter people in a cohort or kind of continuously entering. You can also like match it with Psychosocial or make it optional to have like both programs running, like a CRA or a CBT group. But they can be in either of them. And there are some clients who really would prefer this and not attend group. They really dislike group. They don't want to have that kind of programming, and it's nice to have this option, which is like in and out motivation. So typically we would do for stimulants twice a week with your analysis. The analysis might become part of their, if they're on OAT, it might be part of their OAT program. Generally it would last 12 weeks. It's sort of the standard course. And then reinforcement. So there'd be an escalating number of draws. So the first day, and it says this lower, there's priming. So the first day, everybody draws and draws and draws until they win a prize, just to understand that it is possible to win a prize. So it's sort of like turning on that dopamine pump. So everybody keeps doing that until they win a prize and experience sort of, this is possible, this isn't rigged, it's how it works. So it's in the cabinet, you want a medium prize, pick one of these prizes. And then whenever they present with a sample that's negative for the substances of concern, again, we're only looking at the substances of concern. So if there's fentanyl in that sample, that is a separate discussion that happens in their OAT assessment. But anything in the stimulant category that you have on your treatment agreement, we'll get to the treatment agreement, that would count. And then the first time that that's negative, they get 1 draw. The second time in a row that it's negative, they get 2 draws, and that keeps going up to a maximum of 8. And then if they have a slip, they either have a prize or kind of ranging. I think some of the examples would be small, very popular was chocolate. And then we have things like large, I think were like coffee machines. There was like a tablet, sort of like jumbo prizes. You kind of want to have some like jumbo. Any other examples you want to mention?
We had board games too. A lot of patients that were living in shelters really liked board games. So
it's hard to predict. We asked the community sort of what would you want. It's actually a hard question to ask. I don't think people necessarily know. You kind of have to try stuff out and see what's popular and what's not. Probably time of the year matters as well in terms of seasonal needs, things like that. So if it basically resets to 1 if there's a sample that's not negative or an unexpected absence. If there's a planned absence, like going to court or having another medical appointment, as long as it's planned, you can actually just continue on sort of after that. But if it's unplanned, that would count as a miss. And then you really do want to give the prizes right afterwards. So this would just be an example of the number of draws people could achieve. So they would start with 1, and then let's say alternating between Tuesdays and Fridays, they could actually get to a maximum, like to a full, 8, and then they could just like continue to stay at 8 draws every time. So the book actually talks about the importance of the results slip, which is like every time saying, you earned one chance of winning a prize today for providing negative samples one time in a row. If you provide a negative sample on Friday, you will earn 2 chances of winning a prize. Our patients didn't like this, and the slips went everywhere, and they were all over the floor, and it was like a big mess. And so we had to unfortunately abandon this just because like it was unmanageable to have this much paper everywhere. But I don't know. I mean, I'm interested to hear like if there are other ways of doing it that would be more helpful. Certainly verbally just telling patients was also effective. So as much as possible, we really tried to stick to the model exactly as it is, because that's how it works. And attempts to modify it are going to make it less effective. This was one of the rare things that we had to change, but generally this was done as really as strictly as possible. So costs.
So cost was probably the most challenging part in implementing CM. We ended up kind of launching with donations. It cost us about $265 per person for 12 weeks, and that was with donations. So we received like bus passes, Tim's cards, lots of chocolate. Also, you have to order. The other larger costs were having dips on hand, because you had to have 2 dips per week for each patient, having your cabinet, a slip bowl, stationery, and then staff. CM works best with 2 staff. Just because you have to be able to do the test and immediately go to the prizes. It takes about 15 minutes twice a week. And if you have a lot of other things going on at the RAAM at the same time, which I'm sure everyone does, having that second person to be able to give the prizes, talk to the patient, really helped smooth the process over and didn't make it overwhelming. Okay, so initiating CM with a patient. So this was done typically before day 1. We would have the patient sign a treatment agreement, and we would go through and explain the risks, rules, benefits to it. And then we would give them a tour. We'd show them how urine sampling worked if they weren't previous OAT patients. We'd show them the prize cabinet. We'd show them the slip bowl. And then we'd set up a schedule with them twice a week to when they were come in. And then we offered flexibility in times. Most of these patients cannot stick to a schedule in terms of like a set time. So you can't say like they're going to come in every Tuesday at 12. We'd say you have to come between 8 and 12 just to kind of give them leeway. We give them a calendar as well to kind of track when their appointments were coming in, and then they could also track themselves if they were negative or positive and how many prizes they were going to win. And then we had a counselor or case manager sit down and create like a weekly schedule with them to help and discuss strategies to avoid using. One of the bigger benefits to this was we had a peer support worker when we launched kind of in the waiting room assisting patients, and she was actually a huge advocate for convincing patients and showing the benefits to the patients. So I strongly recommend peer support for this, because sometimes when you're starting, it can be overwhelming for a patient that's never heard of contingency management. It's a new treatment, it's a new therapy. So having some peer support was an additional help.
Right. Okay. So somewhat quickly, there's stimulant-induced psychosis. I think just briefly, I think this is really important to mention, because these patients, I think, more commonly are presenting to substance use treatment than to other aspects of the mental health care system at times. And when they're seeking care, it's really important to provide care and to try to provide as much treatment as possible, depending on what people are looking for. So really just any substance-induced mental disorder is just a disorder that's not better explained by a non-substance-induced disorder. So we don't have something where the symptoms actually predated the substance use. The symptoms don't persist generally around a month after the substance use, and there isn't other evidence that there's some other non-substance-induced disorder, like recurrent episodes of the same symptoms. So it is helpful, and again, I think one of the reasons why RAAM clinics are really can be really important in the treatment of this is that urinalysis can be helpful in trying to figure out sort of the temporal relationship between the substance use and the symptoms. So similar definition for other disorders related to stimulants. So the complexity is sort of like, what do you do in the practical real world where you're not sure the patient's saying, well, I think I was diagnosed with something before, and I'm not sure, it was maybe bipolar or maybe schizophrenia or maybe borderline personality disorder. And, you don't have records, and you don't know what the symptoms were like, and you don't know if they were substance induced at that time, and there's nobody that can provide a history to you. It's, I think, in the literature very clear, reassess after abstinence. But what do you do in the moment when that isn't happening right now, and that isn't something you're not sure when that's going to happen in terms of achieving abstinence? So in terms of the specific definitions, just compared to schizophrenia, so certain criteria like disorganized speech or disorganized or catatonic behavior, negative symptoms, those are within the criteria for schizophrenia. For a substance or medication-induced psychotic disorder, you're really looking more at the positive symptoms like hallucinations and delusions, that this is in some way related to the substance and it's not better explained by something else. And also that it causes distress. If someone's absolutely not distressed, and certainly many clients will say, I see shadow people when I hallucinate, when I use, but the rest of the time I don't see anything, I'm not worried about it. That's totally different from someone who has, significant distress from psychosis, even if it's only in a brief period. There is some literature on this. I think certainly this is not something we can be certain about. It's very difficult to know whether something is stimulant induced or not based on the kinds of symptoms. Generally, they seem to be more persecutory and referential delusions with more auditory hallucinations, as well as some disorganization, hyperactivity, inappropriate affect that can also occur. There's usually less in terms of negative symptoms, but again, this is not, it's not easy to provide a diagnosis based on these criteria. I do think it's helpful to think that the persistence of symptoms can definitely be quite common. So as much as we have that 1 month criteria, for many people, like up to a quarter of people, you can really look at persistence after a month. And up to 40% of people in some studies have persistence of psychotic symptoms. So what should we call that? Is that sort of other psychotic disorder? It's not exactly schizophrenia. There may be more insight. It's quite difficult. I do think that's certainly a time, if it's persistent, if it's causing distress, that seeking referral is quite helpful. Which is why we're very integrated to try to provide that. And I don't know the exact statistics, but I would say like a significant bulk of consultations for psychiatry in the RAAM would involve psychotic symptoms and would be related to stimulant use, even though there may be other substances and other disorders also involved. And so the things that may predict this transition to schizophrenia or to chronic psychosis would be just the substance itself, like methamphetamine, that predisposed individuals through other concurrent disorders, trauma history, family history may be more predisposed, and then a combination of both of those really occurring, because that is really the Venn diagram as sort of we're seeing of the experiences that people have. I just want to mention this paper a couple of years ago, which is really striking, which is that you have significantly reduced odds of seeing a psychiatrist in the 30 days after an emergency department visit for individuals who visited an emergency for a substance use disorder. So presenting 5 times for a substance use disorder dramatically reduces your odds compared to somebody who doesn't have those visits for a substance use disorder. So these clients, again, that comes back to that CBC article at the beginning, they may be presenting to a methadone clinic, they may be presenting to RAAM. It may be very difficult for them to access services in sort of traditional psychiatric spaces. And so, starting a process of engagement, trying to bring services to a more accessible place, I think has a really important role, and more integrated care in particular. So in general, so again, sort of getting back to with, are we treating the use disorder or the psychosis? So for the psychotic symptoms, generally speaking, second-generation antipsychotics are recommended with a tapering attempt at 6 months to determine if they are necessary, presumably in the context of discontinuing the use. There's some concerns that these substances could promote cravings due to dopamine blockade. But in general, our experience has been, to consider treatment, particularly if there's distress and what the outcomes of that distress are. So again, I do think, it's very much a risk-benefit discussion with the patient. If these symptoms, particularly when they're worse, have resulted in threats to others, to harm to themselves, to incarceration or charges, to really dangerous medical situations, these are all things where it's important to have a discussion about, yes, there's certainly risks with antipsychotics. These are medications that can cause a number of metabolic and movement disorders. But at this time, in this scenario, is it important to try to treat these symptoms of psychosis? And I think from the RAAM experience, again, you look at the literature and yes, absolutely important to obtain history as much as possible. But if we just don't have a history, if somebody has moved from another area and we just don't know what that symptom was 3 years ago or 5 years ago, if abstinence doesn't seem likely, we've engaged with this person for several months and it's been very hard to achieve any kind of reduction in use. Is there insight into the symptoms or not? And I just want to mention, so I think there's things you can treat in the RAAM. If there's an acute safety concern, if somebody is, obviously immediately in danger to themselves or to others, or completely, in a risky situation of caring for themselves, that's also, a situation to consider whether, they need an emergent transfer to a hospital for treatment as well. So if they are having really profound psychotic symptoms, that's another reason, they may need an emergent hospitalization and transfer to hospital, and also sort of what you can safely manage in a RAAM clinic, right? There are other people in the RAAM clinic, just making sure that that everybody is being safe. And RAAM clinics are not psychiatric hospitals, and I think that's also really important. Other things to consider is just that if a stimulant medication has resulted in psychotic symptoms, certainly prescription stimulants can also do that, particularly amphetamines. So we wouldn't recommend replacement therapy for somebody where there's psychotic symptoms. And certainly just caution around prescription stimulants for any reason, such as ADHD, if there's been psychosis, and especially if that psychosis has resulted in major safety issues for them, their ability to care for self or for others. For many clients, we actually offer long-acting medications, and again, a fully informed consent discussion of you've tried this medication, it's worked for you. Would it be helpful to kind of have this on board? Because some clients, if there's an intermittent severe psychosis, again, that leads to a significant safety risk, it may be worthwhile to try to prevent the severity of that psychosis in advance, especially during a period where they're really trying to reduce their use and there's lapses and they're really working very hard at their recovery. And so adherence being a big issue. So again, the evidence is not great, but it is recommended for the psychotic symptoms. Certainly anybody taking any antipsychotic for any reason, whether that's for, adjunctive treatment of their depression or bipolar disorder, or any other reason, do need monitoring for any kind of metabolic side effects. And so there's good guidelines I've included. You can follow here for baseline and follow up, and then also movement disorders, which can occur. Also, just to consider in acute intoxication, which I said we weren't going into, but just briefly, there is a risk of lowering the seizure threshold or increasing the risk of rhabdomyolysis or extrapyramidal symptoms. I also want to mention, again, there might be some synergy. So for most of these off-label indications, if there is an on-label reason, like a clearly documented history of bipolar disorder with multiple hospitalizations, that would be a reason, obviously, why they might be on an antipsychotic, for example, and maybe that's an oral antipsychotic that has a long-acting formulation. So maybe that would be a rule to have a discussion or to involve, a different prescriber and say, what do you think about, transitioning this to a long-acting? Okay. So now, a really important, I think, slide again is just the bigger picture, and we didn't get into the data, which is not as much data, but certainly about sort of combining things. But I think the big thing is just having this entrance for people that's ground floor entrance where everything is all in one place. And so it's not so much the CM on its own that is going to do everything, or the mirtazapine on its own. It's kind of this whole place, right, that has all these resources that, especially when someone has neurocognitive side effects from a substance potentially, and a lot of other adversity that they're dealing with in terms of housing and food security, to have a place where some of these things can get sorted out and they don't have multiple appointments. So these are just some of the multiple things that are happening. There's counseling, there's case management. So many people don't have ODSP who are completely eligible for ODSP. So trying to figure out their ODSP, right? Getting them connected with ODSP services or OW. They don't have drug coverage. Getting them connected with drug coverage. How are they even going to access? They may need OAT and they can't access that. They need primary care and they need a referral. Anything you want to add to that, Stephanie?
No, I think that's just emphasizing it's like a team approach. You kind of need all hands on deck when you're trying to treat patients that have stimulant use, and kind of their quality of life is all over the place. You need everyone to help. Okay. So strategies for and tips for implementing stimulant use at the RAAM clinic. So we created an intake that combined both the medical and psychosocial needs for the patient, and this is always done on day one. In our experience, like patients, when they walk through the door, you really have to sell day one to a patient coming in for stimulant use. It's not like methadone or Suboxone where there's always like this continued reason to come back. So the patient often identifies like what their goal is the first day, and you have to roll with whatever their goal is. So if they walk in and they're like, I don't really want to treat, my psychosis, but I really need housing today. Your goal on day one is to work on housing. So we always try to attach our patients with like a case manager. We use coordinated care plans to communicate this between different agencies. So if you have high-risk patients that are going to the hospital, coordinated care plans, you can often put their medication, their current treatment plan, all their supports in place. That way, if they end up going to different services in the community, you're all kind of on the same plan. We use a multidisciplinary teamed approach at RAAM to help the patient's short-term and long-term goals. Most of the patients that walk through our door cannot attend 4 to 5 appointments in a day in different locations. So the idea is to have like an all hands on deck approach and to have all services in one area so that you can get the patient attached and getting follow-up care at one appointment. You have the most likely outcome for success for the patient. If they're missing appointments, it's really important to follow up. A lot of patients get lost in the system. Follow-up phone calls often have helped us know that patients have been in the hospital or they've been kicked out of shelters. It helps us to really track patients down. And then setting up case conferences or patient rounds for challenging cases. This is something we end up doing for a lot of our stimulant patients. It really helps kind of keep the plan together and the team on place and, to seek out support if we're struggling. Okay, so treatment planning for harm reduction. So if a patient walks through the door and their goal is not to reduce use or to stop completely, we provide medical treatment based on the patient's goals. So some of the patients might walk in and say, my goal today is to treat my depression, and that'll be the focus of the day. We'll assign them a case manager, and then we'll assign counseling based on their goals. So if they're having, if they have trauma, we'll do seeking safety. If they have depression, they'll see a counselor for that. They'll do relapse education. And then we give out harm reduction supplies to patients that are using stimulants just to prevent them from getting Hep C. Naloxone is a huge component. A lot of our cocaine users do not identify that fentanyl would be laced in. So it's a really important conversation we end up having with our patients to let them know you have a really high chance of overdosing. So please consider taking naloxone. And then we set up weekly appointments for our patients that are coming in, even for harm reduction. Connection is probably the most important piece for treating stimulants. A lot of our patients get lost in the community. So having that one place they can walk into every week and see all their supports and see a doctor moves them along from harm reduction to wanting to reduce their use. Okay. And then if their goal is to stop using or reduce using, very similar, but we add other components. So contingency management, we will offer that after a few weeks if the patient's been interested in wanting to reduce or stop. We add community reinforcement. We partner with community withdrawal management if patients want to have like a period of abstinence or if they're homeless or want to try it out. A lot of patients in the shelter system often get lost trying to attend community withdrawal management. So we partner with like community pharmacies, and we'll use them as like check-in points to try to get patients access to beds. And then for patients that want to stop using, we use biweekly appointments, especially if they're on contingency management. Okay. Strategies for scheduling. This was probably the most challenging task when we launched, because it was trying to figure out how to have multiple populations coming in. You have your middle-aged patients that are struggling with an alcohol use, and then you have stimulant patients coming in. For our patients, we always offer our initial appointments on a walk-in base. They have to want to come in that day. We don't try to make it scheduled because it's a lot of pressure. Our follow-up appointments are scheduled days, but not usually scheduled times. Scheduled times usually just don't work for this population, and it's really overwhelming for them to have to consider and try to remember a time, and if they miss the time, they just don't come. We try to encourage them to attend when the clinic is less busy to avoid long wait times. And then we always have quiet space available if our patients are paranoid or agitated. This is so important on day one. If you have someone that walks in and they're really paranoid, agitated, they're really not trusting you, you have to have them kind of in a quiet environment, and you want to kind of get through the intake as quick as possible to create that warm environment that they'll consider coming back for the next appointment. And then we do in-person visits for patients that are experiencing paranoia or psychosis. Some of our patients really struggled with OTN and phone visits, and I know during COVID that's the preferred. But for these patients, they would stop treatment if we didn't offer in-person visits. So we use social distancing and safety measures in place at the clinic and still continue to offer that. And then we follow up with no-shows. We don't have literature to cite this, but food and snacks are so important to keeping our patients coming back. If a patient has been having a few days and they've gone out like using cocaine and they're kind of falling asleep in the waiting room, snacks keeps them going so that they can, be more engaged. Appetite increase is a core symptom of stimulant withdrawal. So giving them snacks often keeps people in the doctor's office, going to appointments, making it to case managers. Can't emphasize enough how important it is to have snacks and socks and those pieces, because often that's the patient's goal. Okay. And then daily dispensing and daily observed dosing of medication. So for our patients that are using stimulants, if they're having medication adherence problems, they often don't want to go take their medication every day. If they're struggling to leave, a lot of patients that live in shelters, they might not be leaving, they might be sleeping all day. Having them go to the pharmacy every single day, check in, take their medication in front of someone often improves compliance. It ensures they're taking the medication, especially if we're looking at a long-acting injectable. Making sure they're taking the medication is key. And then it also helps with their daily routine and altering their drug patterns. If they know that the pharmacy is only open till 3, they'll stop using at 5 in the morning so they're awake to be able to go to the pharmacy. It improves attendance and other appointments. Most of the time, in our community in Brantford, at least, we have the pharmacy, Ontario Works, it's all in the same community. So once we've got them up out of bed, we have a better chance of getting them to the other appointments. And then daily connection with a pharmacy staff member. It's been so helpful. This was kind of my background before I launched into RAAM. And it was, you're working in a pharmacy that mainly specializes in addiction, and you see patients that are kind of falling through the cracks and missing appointments and not getting them, not making it to withdrawal management, for instance, because they don't have access to a phone. When you're working with a pharmacy, and the patient's going to the pharmacy every day, it becomes their touch point. So case managers will call, the withdrawal management will call and say, I have a bed. And then you can get the patient there, you can get their medication there, and you have a better chance of increasing their success in stopping stimulant use.
Yeah, so thank you all for your patience. Sorry, it's a little long. It's hard to practice over Zoom. I think we're all still, after 9-10 months of this pandemic, still getting used to this, but.
Well worth it. You guys covered so much. I kept writing down questions and you kept answering them as we went. So for those who have questions, please keep putting them in the chat. I'll start with going back to contingency management, and a question that I think is on everybody's mind is, how does this get paid for? You alluded to the fact that the cost is significant. So when you went to the community to ask for donations, who did you go to and how did you frame it? And then where did you draw the other actual monies from in terms of pot to try to support the rest of the steps in the program?
So how did we went, our RAAM clinic is multiple agencies in one. So we started with going to our leadership table and we brought a presentation, basically explained the benefits. And we said, most of our patients attending the RAAM, we had, I think 44% at the time were using stimulants. And I said, this is the best thing we've got to offer. So it was multiple agencies that kind of said, well, I have a bag of socks. And so they gave us like 200 pairs of socks. And then someone said, I can donate 50 gift cards. I'm not going to lie. We even got scuba equipment at one point.
Don't recommend that. Do not recommend.
Yeah. But it was extremely rewarding once we seen that it worked, because we've seen a lot of success with our patients. And then it was easier to kind of convince agencies to agree to add more funding.
Mm-hmm.
Yeah, I mean, I think partly just like if you can get enough to like show that you've got the ball rolling. I mean, my hope personally is just that if we all advocate that this is something, that works, that is reasonable, that is highly evidence-based, that there will be a funding pathway sort of within, something like, ODB, or there'll just be a way to like actually fund this. I mean, I think that is a problem that needs to be solved, and it's not solved by any means at this point.
So $250-ish per person, just for those who are trying to think about how to find some money in addition to those donations to create an array of prizes. Yeah, it's not a small amount of money, and you're right. You want to be able to demonstrate somehow that it was working, and I guess working is helping people meet their goals, whatever those goals are, right? Because I kept thinking about how do you know what it is that's working, but you spoke to the clients identifying their own goals initially.
Yes, it's really about improving quality of life for them, and that's what kind of keeps them coming back.
Yeah. One of the questions was about how many addiction counselors are in the clinic. It seems like it's so well organized, and it does seem like you are so coordinated in terms of the services. So before I forget, I want to ask as a part 2 to that, you talked about coordinating team plans, and I'm really curious about whether there's some kind of platform or how you're doing that. So that's a 2-parter.
Okay, so for addiction counselors, we have 3 concurrent disorder clinicians, and then we have 1 mental health social worker, and then on site every day we have 1 case manager, but it's probably like 5 or 6 different people that sub in and out. And then, sorry, part 2 of your question was coordinated care plans.
Yeah.
So this is actually available already across the province in all regions. It's like it was developed by the LIN, but I think most government agencies have this already out. It's just like a template. Not a lot of people use it, but it has all the information that's in it. So once you're using it, it's really effective because there's also like a system called Chris that has all of these plans looped in that you can kind of view it. And it shows up on Clinical Connect and Connecting Ontario. You can see these plans.
And okay, you answered that question. I think that there are a lot of agencies, and especially community providers not working within, a supported agency that don't know about that or have access to it. So thank you for that. A question about, in terms of the contingency management programs, do they go on indefinitely? Is there a start and stop? And then there was a question that also spoke to that around how do you follow people, and what's the evidence for after the program has stopped that there's ongoing benefit? Yeah,
I mean, the evidence certainly, there are concerns when the trials have ended, that people can relapse back to use. The evidence is generally around a 12-week course, and that's also similar for community reinforcement. The idea is the sobriety sampling, so providing a 3-month window of of treatment engagement to sort of facilitate treatment. Again, I don't know that there's good evidence for exactly, I think, what most people are intrinsically doing, which is to say, in addition, and this is the time where while we're doing this, we're trying to also make sure your ODSP is set up and that you're on the housing list and that you're in a better shelter and so on, and trying to do that all at the same time. But yes, I mean, because the research studies are generally 12 weeks, and also because of the funding issues, we have just chosen that sort of standard model. Afterwards, people would still have access to psychotherapy groups that have, which we didn't even mention so far. So we've had a couple of groups running, and some are still running in COVID. Individual therapy, connection to other community resources. So those things would again come into play.
And do you see any disappointment? Like, if someone has run their 12 weeks, they're still connected to your services, they may have been doing okay and then not so okay. And, is there...
The problem is we were doing this and then COVID hit. Mm-hmm. So we don't know yet exactly what that looks like because we've had no choice but to modify, but basically just in terms of keeping numbers down in the clinic. So that's not something, we really know. I mean, they do address like a lot of those questions in that textbook, sort of about how to talk to people about this being, a targeted treatment. Something that I don't think has very much evidence, and I'd also be interested to know more about, would be how family members can use these strategies. So we do have some clients, I think everyone who have concerned family members who'd like to be involved. So there is a CRAFT manual, which is community reinforcement and family therapy, which is how to use kind of the same principles in order to reinforce behavior in one way or another. So not interventions is like very positive, like, when we go out for ice cream, we have a really good time and you like it and you don't use that day. So let's do that. And instead of me yelling at you, which causes you to feel shame, and then you use. So I think those things linking to like other evidence-based interventions that use the same principles would be really interesting.
Mm-hmm. Before I leave back to pharmacology, any other sort of suggestions about COVID modification? I mean, everything that you're talking about sounds so hands-on in person, which we are all missing incredibly. It sounds like you're still trying to run, though, with some modifications.
Yes. So we've been kind of looking at how we can modify moving from a slip bowl to like a wheel, an electronic wheel, to avoid hand touching.
Not grabbing.
Yeah. And then, having a case kind of in front of prizes so they can see it. And then like someone else, just one staff member kind of grabbing prizes for people. And then reducing kind of the amount of patients you're having in the program and how many are coming in. It requires more scheduling for sure, but it can be done.
Okay. Back to medications. Tanya, there's a question about whether you have any experience with dizipramine.
Yeah, I don't personally. I did not see it come up significantly in the literature. There wasn't really great evidence for any of the antidepressants, and there was just that like particular concern with sertraline, but I'm not sure about dizipramine. I think there have been like a number of trials of a number of different antidepressants over the last number of decades, but nothing's really stood out. Again, I do think if there's a comorbidity, I would be a little bit more worried with dizipramine about side effects, especially patients on methadone and QTC prolongation. I'd be a little bit more worried. So I think, just balancing those risks. If somebody says, I tried this medication 10 years ago and it was like super helpful for me for my mood, and there's another reason, and I'm having a similar mood problem, I think it's really reasonable. I actually would base a lot of the decisions around psychotropics partially around what else you might be treating. Baclofen is also coming up, and beta blockers. I'm not familiar with like significant evidence. Nothing else has really like stood out dramatically in terms of again, I think if somebody with baclofen, particularly given the sort of emerging or evidence in some populations with alcohol use, if that would be, another reason, I think, or again, if you're limited by, significant medical comorbidities and you feel like another agent might be helpful, I think that's reasonable as well.
Thanks. So there's a question about mirtazapine, which you spoke about, but maybe you can clarify this. when you were speaking about the agents that don't have any good evidence at all in terms of antidepressants and mirtazapine, you were speaking about it for stimulants as in crystal meth, not in cocaine or crack.
So those two recent RCTs have been done with methamphetamine. Yeah, they're done. I think we've definitely tried it. I think again, it's sort of like risks of harm. So an SSRI, mirtazapine, something that's like less likely to cause like cardiac side effects, less likely to interact with other things, not as much going to cause movement disorders or sexual side effects or other sort of problematic side effects. I think partly that's part of the reasoning. But yes, the evidence is really around a fairly specific population that was using methamphetamine. It wasn't even, I think you could argue, is it broadly applicable to everybody who uses methamphetamine? But given how few things we have.
I think you mentioned that in terms of the role for stimulants, that looking at the Cochrane review and across the literature, that you didn't find evidence for stimulant replacement to be supported in the literature. And there was a question about whether there might be some evidence or some rationale for using in terms of withdrawal management. Can you speak to that a little bit?
I mean, I think it was helpful. And I do want to clarify, like it did seem to have some benefit, especially in cocaine for abstinence. It just wasn't very good at retaining people in treatment. I think that hopefully that evidence will grow and especially around parameters of doses. I wonder, since we're worried about doing harm, if the doses are, tend to be on the lower side. And so actually the studies with higher doses tend to be more effective. It just doesn't seem like a clear enough, evidence to really proceed with it in the same way that we do with OAT. Sorry, what was the second part of your question?
That there was a suggestion about withdrawal management.
So it did seem to have more evidence in withdrawal. I'm not, again, certain about sort of enough. I think, without sort of clear guidelines, I'm just personally a little bit more reluctant to use something without clear guidelines that has more of a risk, of harm or dependence. I do, but it's a good point. I think having more evidence. I do think as well, in terms of stimulant withdrawal, sort of a lot of the supportive measures are actually quite safe and helpful. So if you think of like opioid withdrawal, we would not want to, we would not want to expectantly support people. We really want to provide that replacement for safety and overdose. It's very different with stimulants. I mean, I think we do find, we do use olanzapine. That's more for agitation and psychosis, which it does have evidence for. And that mostly it's about like a calm, supportive, like the essential part of stimulant withdrawal is really to have like a safe, supportive, calming environment. So, but potentially if we could get more evidence about how to use stimulants in that setting, it would be really interesting.
Would you look at any of these approaches differently in someone who either had a formal diagnosis of ADD, ADHD, or as in many of the people that we work with that was potentially not formally diagnosed, but everything about them sort of screams ADD to you?
I think it's really hard to tell. And I don't think it's not a really well-researched and understood sort of thing. Certainly because patients present to us without, their records from, 2 years ago, let alone childhood. So technically the diagnosis should be made prior to the age of 12. I think that's the really hard part. I think the question is the utility of a stimulant treatment. If somebody's having these profound symptoms from methamphetamine, which we're not going to probably be able to replace to that level of dopamine release, and the safety and utility of that. I think if you can demonstrate that somebody had a good response in the past and that it went well, then certainly, carefully observed doses might be reasonable. I do try to get collateral. I mean, I think definitely if you can get collateral, from a family member or from records are harder, like report cards are definitely very hard to obtain, but like a family member. And clients will, I think often if you ask, will have a phone call with their family member, with their parent or their sibling who'll say, this is what this person was like when they were, 5 or 10. And sometimes, and they were treated for like a period of time in their teens or something like that, then it may be reasonable. I do think it helps to have some stability if there's really unstable use, and also what the goals are. So if this were treated, how would we know that this is working? What would be easier for you? Like, would you be able to like engage with your ODSP worker? But I just sort of emphasize caution because, again, if there is psychosis, if there are a lot of other kind of concerns, just to kind of be aware of all that.
Yeah, right. And concerns around cardiac risks if someone is using both street stimulants and their medications. There was a comment about using non-stimulant medications such as bupropion and atomoxetine, of course.
I say again, although like maybe evidence is limited, it's definitely safer. I think we do a lot of bupropion for that reason. Although we are sort of also mindful of misuse of it. And venlafaxine has a little bit of evidence as well atomoxetine. I think, again, to try to minimize the polypharmacy, patients can easily end up on a lot of different medications. So venlafaxine, for example, there may be some benefit for attention, even if we're not really sure if it's ADHD. It's also first line for PTSD, which is very common in our population. And it's also first line for depression. So that might be more our selection. But bupropion is very good.
And QT prolonging for our patients who are on high-dose methadone. So, right, but I appreciate you saying, in this world where so much is unknown, if there is evidence for a specific treatment that fits one of the diagnoses, then that makes sense. I don't know if there's anyone who's in attendance who's been part of any of the stimulant replacement programs in any of the COVID shelters who wants to comment. I mean, I do think that is a specific setting where I know there's discussion as opposed to sort of longer term outpatient treatment. So if anyone has anything to post about that, that would be welcome. And there was a question about how to gain access or upload treatment plans to Ontario Clinical Viewer. Is there an MOH contact? I have no idea how to answer that, but I can maybe someone else who's part of the listserv who knows that can either respond here, respond on the listserv, or I can do a little bit of digging with our Connecting Ontario contact. It's not something I've ever initiated. I've been part of some treatment plans that have been provided through the Health Link, but it quite honestly hasn't happened in a while.
I can provide like the contact for like Brand Hallam in Norfolk. I know it's not helpful for Toronto area, but they might be able to connect you to whoever is launching it in Toronto.
Right. I'm sure there's a counterpart, right? Or, Thunder Bay or where Greg is or anywhere else. That would be great. There we go. ehealthontario.ca. We'll make sure that we thank you, Lindsay. This is available to everyone who's on here, and that we'll copy and share that too. I want to thank you so much. As I said, I kept writing down questions and they kept being answered. So that's, I guess, the marker of a great presentation that thought about all of the things that we would want to know. Pretty inspiring to think about the collection of services and the way that you're managing to assist people in your RAAM. So thank you for sharing that, including your RAAM as the third presenter on the session here. And giving us lots and lots to think about. To everyone on the webinar, please complete the session evaluation before you go so that you don't forget. That's really important for us. Our webinars will be running the second Wednesday of each month through the winter and spring between 7 and 8:30 using probably the same format, an hour of presentation, half an hour of discussion. We'll see whether we can find ways to make things any more interactive. And our February speaker will be Suzanne Turner speaking about sustained release oral morphine or Acadian as OHE. So we hope to see all of you there. I'll stay on if there are any other questions for anyone, and thank you all for joining us.
Thank you so much.
Thank you.
Thanks, Tanya. Thanks, Stephanie.